Before we get started about the ICO and the technology, I want to talk about what I'm really here for. So I've been in healthcare all my life, got into healthcare right in college, have done all elements of healthcare. Insurance, yes, I'm the CIO everybody hates because I make you go through eligibility, enrollment, referral, pre-authorization, all the wonderful things, thank you, that impede care. And then after that, I got involved with a lot of public programs, Medicare, Medicaid, CHIP, President Bush's health savings accounts, President Obama's Obamacare, and so on and so forth. So healthcare is all I've done. And over the years, I've realized that in healthcare, one theme is constant. We keep building systems that are supposed to make healthcare more efficient. And each of these systems ultimately serves to disintermediate the patient or the doctor. And over the last 25 years that I've been in healthcare, no doctor has gotten happier, and no patient is saying, wow, I really have more power than I did 20 years ago. That trend line continues. We continue to build highly automated processes for eligibility, for enrollment, for payment, and yet, end of the day, the two people that matter, you the patient and you the doctor, cannot interact with each other more effectively, with more power. In fact, it's the opposite. And that really is the issue that I witnessed both from a public policy perspective, from an insurance system perspective, as a father of a child who needs a lot of care. That is the issue that we decided needed to be fixed. And we're trying to fix this issue not because blockchain existed or didn't exist, but because it's worth fixing. It's too expensive, and it's too difficult to use healthcare. But blockchain gives us an opportunity to do things we never could do before. So let's jump right into it with that background. See if we can figure out how to operate this. Let's do it a simpler way. Okay. So everybody knows healthcare is very complicated, right? I'll give you a bird's eye view. Healthcare systems aren't homogeneous. When you buy insurance, you're not just an insured population. You are in one of these boxes. You're either an active healthy, or you're pre-chronic, or you're a chronic, or you're multi-chronic, or you're post-chronic. You need medical transportation. You are eligible for home care, or you're not. Every single healthcare user ultimately falls in a subcategory. Healthcare is highly segmented, and every segment requires its own systems. So what you end up with is numerous back-end systems trying to manage your case when you are in one box or the other. This is how healthcare is actually administered. Massive segmentation behind the scenes, and each system requiring a very unique set of processes and systems. Let's look at things in terms of numbers. US spent about $3.7 trillion in healthcare costs in 2016. 3.1 billion went to actually doctors and hospitals and home care and pharmacy. 500 billion went towards fraud, waste, abuse, and overutilization, and 100 billion went towards IT systems that are used to manage the cost. So about 600 billion out of 3.7 trillion is actually not spent on care, but spent on managing care. That's what we're after. So what we decided to do is to turn the system upside down. I started as my own client, and I started asking the question, what would it take for me to give up my data center? What would it take for me to give up all these fancy, massive, complex eligibility, enrollment, payment, adjudication, care utilization, case, and care management systems that I so proudly own and spend hundreds of millions a year in administering as a single insurance CIO? What would it take for me to get rid of all these systems? Because none of them actually speak to me as a patient or a father of a patient. None of them actually speak to empowering the provider. So the goal is to rethink healthcare for the benefit of all, including the dreaded insurance company. We're not going to fix healthcare by telling the insurance company to disappear. We're going to fix it by making it easier for them to administer care without having to police care. And that's really the goal. So we decided to build a blockchain solution with a care protocol, first and foremost, which allows us to encapsulate relationships that drive healthcare. There is a relationship called doctor-patient. There's another relationship called doctor-specialist. There's another one called doctor-pharmacy, or patient-pharmacy, or doctor-insurance, or patient insurance, or doctor-employer, or patient-employer, and so on. Healthcare ultimately boils down to very complex intersecting relationships. And we decided that we want to map the healthcare transactions first and foremost on a blockchain protocol that allows us to map all the transactions that ultimately flow behind it. On top of that, we built a patient, provider, and administrative care wallet, which allows us to have the patient interact directly with the provider or the provider directly interact with the insurance company without having to rely upon any centralized system, which then brings tremendous portability. I, as a doctor, can have a wallet that is independent of which insurance company you belong to, but I can accept your tokens to get paid. So in the wallet, we built the concept of care cards. Care cards are highly decentralized applications that can be published by the care provider, the pharmacy, the emergency medical technician, the helicopter pilot that's going to medvac you, or a simple pharmacist or a home care provider. Doesn't really matter. There are numerous entities that drive your care. Those entities need to interact with you and coordinate your care among other entities. The objective is for them to work in a completely decentralized way without being contracted with me, the insurance company. Okay? So inside the care wallet are care cards that will have infinite number of them, depending upon whether we are in China or California or Congo. It doesn't matter. The notion is that healthcare entities, once mapped in the relationship in the protocol, can then be easily effectuated as a care wallet and as a care card. So the care protocol is the underlying blockchain implementation. Why blockchain? Because I don't really need to know you as a doctor. I don't really want to have a pre-existing contract with you for you to see my patient. The last thing I want to do is to perpetuate the mythology that one person knows best. The idea is to do the exact opposite. To say, look, Mr. Patient, Pradeep, you are an insured of Cigna. Here is a Cigna wallet with a Cigna coin. Go see the doctor you want to see. And if that doctor will accept the Cigna coin, I'm done. The coin will tell the doctor how much they will get paid when they finish serving you when they enter the 5-digit ICD code. I don't want to see a bill from the doctor. I don't want to have a pre-existing contract with them. I don't want to tell you that you can't see John, but you can see Jane. I want to simply let you get the care you want, but I still want to control cost and utilization, because that's my function. The same is true for Medicare or Medicaid or CHIP or VA. There are thousands of medical programs out there in the world. Each of them ultimately has someone who writes a check. That person should be able to facilitate care and pay for it without having to police it. So fundamentally, healthcare is all about relationships, right? Who is referring you to whom? Who is delivering you the test results? How do those test results get coordinated with the primary care physician, the secondary care physician? How do I make sure all the parties stay in sync? That's the job of the chain in the end. What the job of the chain is not is to serve an electronic medical record repository. That's not what we are trying to do. We're not trying to be a big EMR on the chain, somebody else's problem. Maybe you'll never put your medical records on the chain. Our goal is to transact on events and data and financial transactions and eligibility and enrollment information, not your medical records, not your x-ray, not your diagnosis, not the nurse's notes. It's about managing care, not being electronic medical records. Now, I heard earlier the panel speak about not everything should be on the chain. We completely agree. You should not put everything on the chain just because you can. There are many performance, security, and regulatory reasons. We are focused on ensuring that the chain is used to decentralize and delegate authority, not for storing records that as easily can be stored in an electronic medical record off the chain. So what are we really after? 4 things. Improve access to care. Stop the barriers to access. Drop them down because those barriers arose for administrative reasons. Believe me, there is no single massive conspiracy going on in an insurance company sitting there plotting how to prevent cares for you. No insurance company board sits there and plans to deny care. Their job is to manage cost of care, utilization of care, and appropriate use of care. But along the way, those processes feel like to the consumer, to the physician, as if they're designed to stop you from getting care, to deny you care. Look, at the end of the day, if you're going to get sicker, it's only going to cost more money. So it is never in the interest of anyone to deny or delay care, but it happens because the processes are highly centralized and highly inefficient. So that's what we're trying to fix. We're trying to make the job of the insurer, the doctor, and the patient a lot easier, and also to break down what is called provider network boundaries so that you're not limited to your Cigna network or your Aetna network. You can go see the doctor you want to see. Second is reduce administrative cost and friction. I want to talk about one thing that you may not know. Studies show that every 6 minutes of time a doctor spends with you clinically, spends 24 to 30 minutes doing administrative work around your visit. So they practice medicine 20% of the time. I don't think any doctor got into medicine or being with the goal of being the really best data entry clerk on the world. But that's what they do. Why are we doing that? It's repetitive, it's a very, very dehumanizing and inefficient way of doing care delivery. And it goes back to because we can carry around what is appropriate delegation of authority. The third is timely and accurate payments. 93 days average wait time from the day I deliver service. So I serve you, then I bill, then I wait. And then I chase. And then I plead, then I beg, then I appeal. That's not the way medicine should work here or anywhere else in the world. So the idea is to make payments real time or near real time. And the last is implement value-based care. We all hear about this, accountable care organization, value-based contracts. The idea is to pay the doctor to treat you, to get you well sooner, not to maximize the number of procedures and steps you go through. It's about outcome. Let's make you healthy quickly and pay the doctor that gets you healthier faster more money, not less money. Value-based care is a revolutionary concept that started in the US 5 years ago. It's gaining traction, and every insurer in the world recognizes that value-based care is a better payment model. But it's very hard to implement. Again, you can use the chain much more effectively to manage, control, monitor care without getting in the middle of it. So with that said, here are the 7 functions we are putting on the chain with the intent of getting out of the middle. As an insurer, I don't want to have an enrollment call center. I don't want to have an eligibility center. I don't want to have a referral management team. I don't want to get you a bill. I don't want to have to make a payment to you in the form of an EFT every single transaction. I don't want to be sitting there telling the doctor how to measure their quality. I want peer quality reviews. And I certainly don't want to be managing costs 90 days after cost has been incurred, which is what we do today. So decentralization of those 7 functions to the advantage of patient and provider in a way that I don't lose control is our mission. So this is cut off a little bit, but what does it mean to the patient? I can see the doctor I want. I don't have to call and do eligibility checking. I don't have to come ask some centralized call center, hey, can I go see the doctor? How many visits do I have left? How much is my copay? What's my deductible? What's my co-insurance? What's my out-of-pocket maximum? All these wonderful things. You shouldn't have to do any of that. You won't. I shouldn't have to call and beg for an appointment from physicians who are not available. I should be able to publish my need and get a physician to see me. I should not have to reconcile this craziness of EOBs and bills and co-pays and premium and co-insurance that once I've been to the doctor for the next 3 months, I'm going to have a stack of bills on my kitchen table that are indecipherable. And I certainly don't want to be responsible for costs I didn't plan for. On the doctor's side, I don't want to spend 20 minutes on eligibility. I don't want to be fixed into a contract with an insurance company before I can see you, because I may never get enough patients to make it worth my while to sign up with the insurance company. I want to see a patient, not an insurance company. I want to be able to get paid, not bill and wait and chase, and I want to be able to practice medicine, not practice data entry. Those are the objectives we are after from a decentralization of processes. And then as an insurer, I don't really want to have an eligibility call center. I don't really want to get bills for things that I would pay you anyway. All you have to do is to tell me what you did. And I sure as heck don't want to have everyone hate me because I seem to be the policeman when all I'm trying to do is to manage cost and manage utilization of care. So with that said, we have moved this idea. We started building the platform about 2 years ago. We are now going live with a major organization as in your neighboring state. Arizona Care Network is an accountable care organization owned by Dignity Health, Tenet, and Abrazo, 3 major healthcare delivery systems in the state. Collectively, they are going to launch our platform first in Arizona, then in many other states. That's our plan. 5,000 doctors initially, 250,000 patients or families, and about 250 hospital labs, surgery centers, outpatient clinics are their network. That network is adopting our platform to do value-based payments, to do real-time payment and eliminate the whole cycle of billing and waiting. I don't think we can hear him. This is the CEO of Arizona Care Network as to why he adopted the platform. I think you cannot hear him.
Solution together that will truly transform healthcare delivery, specifically in the payment area within the United States and then later in the rest of the world.
Let's move forward to this last final statement. So there's a lot of question about what are you selling in an ICO? We are doing an ICO end of the month. We're doing pre-sale right now. We are doing what Sydney and I have talked about this for many, many months, that the whole debate about whether you're a utility token, you're a security token, is somewhat moot in my mind. Just believe that you're a security, even if you are a utility, and comply with the law. That's our position. So we are a Regulation D 506C compliant sale, meaning we only would allow accredited investors to come in. Whether the law allows for more or not doesn't matter. We're going to stay very conservative. It is, in our mind, a utility token, but it doesn't matter. It's semantics at some point. If you follow the law, then who cares if you're a utility or security? We are selling about 250 million tokens, out of which we have sold about 70% already. And we plan to sell the remaining 100 million tokens in our token sale. That'll be 2 weeks, March 31st through April 15th. And we expect to be fully subscribed, or rather oversubscribed. Really, I want to go back to what matters in the end. We are after delegation of authority to the patient and the doctor. That's what we are after. We're after using the chain to decentralize processes in a way that I can let the doctor and the patient interact with each other using my money, but to spend it the most wisely that they can. And we want to improve care outcomes. We want to improve the access to care, and we want to pay more accurately. And that's where the chain becomes exciting. Because if I go back to any other mechanism, I have to have you pre-register, pre-connect, pre-contract, pre-integrate with me. I'm back to being the bottleneck. If I can effectively use the chain to let you go do what you want to do, and I can still control and manage the two levers I care about, cost and utilization, then we are using the chain what it's designed to do. Delegate authority, distribute trust, and verify what happened, and make sure that what happened is what should have happened. That's our use case. We're very excited about what's happening. We're very excited about what Arizona Care Network is doing with our platform. And there are many, many other clients like that behind us in not just the US, but surprisingly around the world. So we would welcome your feedback, thoughts, comments, and how you see this rolling out. And I'll be here for the rest of the day, so please ask questions. Sir?
Suppose a doctor or other health professional wants to look something up that's been reported by another health professional on the patient. How would he access that information?
So the question is, can they access medical data for the patient from some other source? Our vision is that all medical transactions, clinical data transaction happens off the chain. You can put a request on the chain to say, I need to see this individual's clinical data, and that request can be read by another chain, the electronic medical record. But we are not transacting the clinical data on it. We're simply saying, let me give you an example. You come to see me, and I write you a prescription. As an insurance company, he needs to know that you wrote a prescription, but not the content of the prescription. So the care event is a prescription was written. Another event is prescription was filled in the pharmacy. And another absence of event is Pradeep didn't show up to refill, which he should have. So now you know he went, he got a prescription, but didn't show up for refill. But the content of the prescription is clinical data that you only need to know in certain cases. So most of care management and care coordination is actually administrative and financial.
But the insurance company actually wants to know the content of the prescription.
Only in certain cases. You see, let's say if I get 100 million claims a year, 100 million hospital visits or doctor visits from my insured population in a year, I probably would look at 2% of those for clinically. 98% I'm never going to look at clinical data. So it is true that in some cases, utilization review is required, but that's a minority. Majority of the time, I have no interest in looking at your clinical data. I'm only looking at administrative and financial data. Did you go to the doctor? Did you do what you were supposed to do? Did he do what he was supposed to do? Did he bill me? Did I pay him? I don't really need to know the diagnosis code or the procedure code other than to determine how much to pay. So it is absolutely not the case where 100% of claims are reviewed for medical necessity. Very, very few are.
We're running out of time.
Yes.
We can take one more question, but Pradeep's going to be outside, and everybody up have that little green tag. There are sponsors and also presenters. Thank you.
Yeah.
My question's about integration. So a good amount of insurance claim through the Excel process of submitting your CPT codes has been within the EMR system for, like, example, Epic. How would that work with this? Like, how would the integration of this information getting into
Yeah, so billing system is typically decoupled from your care coordination system. So what you're doing is, in Epic, you're running the whole process of care in this scenario you laid out. And in the end, I know the procedure code and the modifier I'm going to code into my claim system. And that billing module is where they would, instead of coding into their historical EDI 837 system, code it directly into the wallet, which would allow them to get real-time payment. So the argument here is simple. You can do the traditional billing, or you can code the token, which you have received in your digital wallet, which is essentially the same process. You're entering the 5-digit code and a 2-digit modifier, but you will instantly know the money you're going to get paid, as opposed to 90 days hence. And the token will establish the value, and you can redeem it tonight. So you don't have to send me a bill at all. Completely eliminates the cycle of generating a bill, sending a bill, reconciling a bill, waiting for payment, chasing payment, appealing for payment, all the wonderful 93 days of pain that we go through.